Chapter 49, Diabetes Mellitus Complications, Review from Class and the Lewis textbook. Chronic complications of diabetes are primarily those of end organ disease from damage to blood vessels. This is secondary to chronic hyperglycemia. These chronic blood vessel dysfunctions are divided into two categories: microvascular complications and macrovascular complications. Microvascular complications result from thickening of the vessel membranes in the capillaries and arterioles in response to conditions of chronic hyperglycemia. They differ from the macrovascular complication in that they are specific to diabetes. Although microangiopathy can be found throughout the body, the areas most noticeably affected are the eyes, retinopathy, the kidneys, nephropathy, and the skin, dermopathy. Microvascular changes are present in some patients with type 2 diabetes at the time of diagnosis. But most of the time, clinical symptoms usually do not appear until 10 to 20 years later. Macrovascular complications are diseases of the large and medium-sized blood vessels that occur with greater frequency and with an earlier onset in people with diabetes. Macrovascular diseases include cerebrovascular, cardiovascular, and peripheral vascular diseases. Patients with diabetes can decrease their risk factors associated with macrovascular complications such as obesity, smoking, hypertension, high fat intake, and sedentary lifestyle. Smoking, which is detrimental to health in general, is especially injurious to people with diabetes and significantly increases their risk for blood vessel and cardiovascular disease, stroke, and lower extremity amputation. Optimizing blood pressure control in patients with diabetes is significant for the prevention of cardiovascular and renal disease, and treating hypertension in diabetic patients results in a decrease in macrovascular and microvascular complications. Hypertension causes an increase in mortality rate among people with diabetes in comparison with those with hypertension without diabetes. Patients with diabetes have an increase in lipid abnormalities, and this contributes to the increase in cardiovascular disease seen in this population. Diabetic retinopathy refers to the process of microvascular damage to the retina as a result of chronic hyperglycemia, presence of nephropathy, and hypertension in patients with diabetes. It is the most common cause of new cases of adult blindness. Retinopathy can be classified as non-proliferative or proliferative. In non-proliferative retinopathy, which is the most common form, partial occlusion of the small blood vessels in the retina cause microaneurysms to develop in the capillary walls. The walls of these microaneurysms are so weak that capillary fluid leaks out, causing retinal edema and eventually hard exudates or intraretinal hemorrhages. Vision may be affected if the macula is involved. Proliferative retinopathy, this is the most severe form, and it involves the retina and the vitreous humor. When retinal capillaries become occluded, the body compensates by forming new blood vessels to supply the retina with blood. This is a pathological process known as neovascularization, and these new vessels are extremely fragile and hemorrhage easily, producing vitreous contractions. Eventually, light is prevented from reaching the retina as the vessels become torn and bleed into the vitreous cavity, and the patient will see black or red spots or lines. If these new blood vessels pull the retina while the vitreous contracts, it can cause a tear. Partial or complete retinal detachment will occur. If the macula is involved, the vision will be lost. Without treatment, more than half of the patients with proliferative diabetic retinopathy will be blind. Persons with diabetes are also prone to other visual problems. Glaucoma occurs as a result of the occlusion of the outflow channels secondary to neovascularization. This type of glaucoma is difficult to treat and often results in blindness. Cataracts will develop in an earlier age and progress more rapidly in people with diabetes. The earliest and most treatable stages of diabetic retinopathy often produce no changes in the vision. So patients with type 2 diabetes should have an eye examination with pupil dilation by an ophthalmologist annually. A person with type 1 diabetes should have their eyes examined with dilation about every 5 years after the onset of diabetes, and then repeat this examination annually. The best approach to the management of diabetic eye disease is to prevent it by maintaining good glycemic control and managing hypertension. Laser photocoagulation therapy is indicated to reduce the risk of vision loss in patients with proliferative retinopathy or macular edema, and in some cases of non-proliferative retinopathy. Laser photocoagulation destroys the ischemic areas of the retina that produce growth factors that encourage neovascularization. A patient who develops vitreous hemorrhage and retinal detachment of the macula may need to undergo a vitrectomy. A vitrectomy is the aspiration of blood, membrane, and fibers from inside the eye through a small incision just behind the cornea. Diabetic nephropathy is a microvascular complication associated with damage to the small blood vessels that supply the glomeruli of the kidney. It is the leading cause of end-stage kidney disease in the U.S. Risk factors for the development of diabetic nephropathy include hypertension, genetic predisposition, smoking, and chronic hyperglycemia. Patients with diabetes are screened for nephropathy annually for albuminuria and measurement of the albumin to creatinine ratio in a random spot urine collection. Serum creatinine is also measured, and this provides an estimation of the glomerular filtration rate and the degree of kidney function. Patients with diabetes who have microalbuminuria or macroalbuminuria should receive either angiotensin-converting enzyme inhibitor drugs like lisinopril or angiotensin II receptor antagonists like losartan. Both classifications of these drugs are used to treat hypertension and have been found to delay the progression of nephropathy in patients with diabetes. Hypertension will significantly accelerate the progression of nephropathy, so aggressive blood pressure management is indicated for all patients with diabetes. Tight blood glucose control is also critical for the prevention and delay of diabetic nephropathy. Diabetic nephropathy is nerve damage that occurs because of the metabolic derangements associated with diabetes mellitus. Screening for it should begin in patients with type 2 diabetes at the time of diagnosis and 5 years after diagnosis in patients with type 1 diabetes. The pathological process of diabetic neuropathy is not well understood. The theories are it includes metabolic, vascular, and autoimmune factors. It is thought that persistent hyperglycemia leads to an accumulation of sorbitol and fructose in the nerves that causes damage by an unknown mechanism, but it does result in reduced nerve conduction and demyelinization. Ischemia in blood vessels damaged by chronic hyperglycemia that supply the peripheral nerve is also implicated in the development of diabetic neuropathy. Neuropathy can precede, accompany, or follow the diagnosis of diabetes. The two major categories of diabetic neuropathy are sensory neuropathy, which affects the peripheral nervous system, and autonomic neuropathy. The most common form of sensory neuropathy is distal symmetric polyneuropathy, which affects the hands and or feet bilaterally. This is sometimes referred to as a stocking glove neuropathy. The characteristics include loss of sensation, abnormal sensations, pain, and paresthesia. The pain is often described as burning, cramping, crushing, or tearing, and is usually worse at night and may only occur at that time. The paresthesias may be associated with tingling, burning, and itching sensation. The patient may report a feeling of walking on a pillow or numb feet. At times, the skin can become so sensitive, hyperesthesia, that even light pressure from bed sheets cannot be tolerated. Complete or partial loss of sensitivity to touch and temperature is common. Neuropathy can lead to the loss of protective sensation in the lower extremities, and coupled with other factors, this significantly increases the risk for complications that result in a lower limb amputation. Foot injury and ulcerations can occur without the patients ever having pain. Neuropathy can also cause atrophy of the small muscles of the hands and feet, causing deformity and limiting fine movement. Control of blood glucose is the only treatment for diabetic neuropathy. It is effective in many, but not all cases. Drug therapy may be used to treat neuropathic symptoms, particularly pain. Capsin is a moderately effective topical cream made from chili peppers. It depletes the accumulation of pain-mediating chemicals in the peripheral sensory neurons. The cream is applied 3 to 4 times a day and is usually an increase in symptoms at the start of therapy, which is followed by relief of pain in 2 to 3 weeks. Tricyclic antidepressants are moderately effective in treating the symptoms of diabetic neuropathy. They work by inhibiting the reuptake of norepinephrine and serotonin, which are neurotransmitters believed to play a role in the transmission of pain through the spinal cord. Duloxetine is thought to relieve pain by increasing the levels of serotonin and norepinephrine, which improves the body's ability to regulate pain. Anti-seizure medications decrease the release of neurotransmitters that transmit pain. Autonomic Autonomic neuropathy can affect nearly all body systems and lead to hypoglycemic unawareness, bowel incontinence, diarrhea, and urinary retention. Gastroparesis is delayed gastric emptying, is a complication of autonomic neuropathy that can produce anorexia, nausea, vomiting, gastroesophageal reflux, and persistent feelings of fullness. Gastroparesis can trigger hypoglycemia by delaying food absorption. Cardiovascular abnormalities associated with autonomic neuropathy are postural hypotension, resting tachycardia, and painless myocardial infarction. Assess the patient with diabetes for postural hypotension to determine if they're at a risk for falls. Instruct the patient to change positions from lying to sitting slowly. Diabetes can affect sexual function in men and women. Erectile dysfunction in diabetic men is well recognized and common, often being the first symptom of autonomic neuropathy. It is associated with other factors including vascular disease, metabolic control, nutrition, endocrine disorders, psychogenic factors, and medication. Decreased libido is a problem for some women with diabetes. Candida and nonspecific vaginitis are also common. A neurogenic bladder may develop as a sensation in the inner bladder wall decreases, causing urinary retention. A patient with retention has infrequent voiding, difficulty in voiding, and a weak stream of urine. Emptying the bladder every 3 hours in a sitting position will help prevent stasis and subsequent infection. Tightening the abdominal muscles during voiding and using Creday's method, which is a mild massage downward over the lower abdomen and bladder, may also help with complete bladder emptying. Cholinergic agonist drugs such as bethanechol may be used. The patient may also need to learn to self-catheterize. The development of diabetic foot complications can be the result of a combination of microvascular and macrovascular diseases that place the patient at risk for injury and serious infection. Sensory neuropathy and peripheral artery disease are risk factors for foot complications. In addition, clotting abnormalities, impaired immune function, and autonomic neuropathy also have a role. Smoking is harmful to the health of lower extremity blood vessels and increases the risk for amputation. Sensory neuropathy is a major risk factor for lower extremity amputation in a person with diabetes. There is a loss of protective sensation, and it often prevents a patient from being aware that a foot injury has occurred. Improper footwear and injury from stepping barefoot on foreign objects are common causes of undetected foot injury. Peripheral artery disease increases the risk for amputation by causing a reduction in blood flow to the lower extremities. When blood flow is decreased, oxygen, white blood cells, and vital nutrients are not available to the tissues. Wounds take longer to heal, and the risk for infection increases. Signs of peripheral artery disease include intermittent claudication, pain at rest, cold feet, loss of hair, delayed capillary filling, and dependent rubor, which is redness of the skin that occurs when the extremity is in the dependent position. Management includes control or reduction of risk factors, particularly smoking, high cholesterol intake, and hypertension. A bypass or graft surgery may be indicated in some patients. Aggressive measures must be taken to teach a patient how to prevent foot ulcers. These measures include the selection of proper footwear and measures to carefully avoid injury to the foot by practicing diligent skin and nail care, and use a mirror to inspect the bottom of their foot each day. Proper care of a diabetic foot ulcer is critical for wound healing. Several forms of treatment can be used for management. Casting can be done to redistribute the weight on the plantar surface of the foot. Wound control for the ulcer could include debridement, dressings, advanced wound healing, and products like bercaplermin, a vacuum-assisted closure, ultrasonography, hyperbaric oxygen, and skin grafting. Neuropathic arthropy, or Charcot's foot, results in ankle and foot changes that ultimately lead to joint dysfunction and foot drop. These changes occur gradually and promote an abnormal distribution of weight over the foot, further increasing the chances of developing a foot ulcer as new pressure points emerge. Foot deformity should be recognized early and proper footwear fitted before ulceration occurs. Necrotic toe before and after amputation. A is before amputation and B is after amputation. Up to 2/3 of persons with diabetes develop skin problems. On the left, diabetic neuropathy, the most common diabetic skin lesion, is characterized by reddish-brown and round or oval patches. They initially are scaly and then flatten out and become indented. The lesions appear most frequently on the shins, but can also be found on the front of the thigh, forearm, side of the foot, scalp, and trunk. Acanthos nigricans is a velvety light brown to black skin thickening seen predominantly on flexures, axilla, and the neck. Necrobiosis lipodica diabeticorum usually appears as red-yellow lesions with atrophic skin that become shiny and transparent, revealing tiny blood vessels under the surface. The picture on the right depicts this. This condition is uncommon and occurs more frequently in young women. It may appear before other clinical signs or symptoms of diabetes. Because the thin skin is prone to injury, special care must be taken to protect the affected areas from injury and ulceration. A person with diabetes is more susceptible to infections. This is due to a defect in the mobilization of inflammatory cells and impaired phagocytosis by neutrophils and monocytes. Recurring or persistent infections such as Candida albicans, as well as boils and furnicles in patients with undiagnosed diabetes, often lead the healthcare provider to suspect diabetes. Loss of sensation neuropathy may delay the detection of an infection. Persistent glycosuria may predispose to bladder infections, especially in patients with a neurogenic bladder. Decreased circulation resulting from angiopathy can prevent or delay the immune response. Antibiotic therapy has prevented infection from being a major cause of death among diabetic patients. The treatment of infections must be prompt and vigorous. Teach patient measures to prevent infection. People with diabetes should practice good hand hygiene and avoid exposure to individuals who have communicable illnesses. An annual influenza vaccine is advisable. In addition, a pneumococcal vaccine, Pneumovax, is recommended every 5 years.